Hello, people. This is Dr. Muskaan this side, and today I'm going to discuss very beautiful case with you. Here is 35-year-old male who has came to ER at 10:50 p.m. with chief complaints of dizziness, shortness of breath, fever with chills, and urinary retention since morning. On primary survey, ABCS was done, that is airway, breathing, circulation, and sensorium. Airway was patent, there were no signs of airway obstruction. For you, what are the signs of airway obstruction? They are stridor, dysphagia, dysphonia, choking sensation, person is holding his neck that he's not able to breathe. So yeah, these are the signs of airway obstruction. On breathing assessment, respiratory rate was 18 per minute. There was no tachypnea or bradypnea. SpO2 was 96% on room air. That means there were no signs of desaturation also. On circulation assessment, pulse rate was 113 per minute, which shows which shows tachycardia. Why tachycardia? Because normal pulse rate lies between 60 to 100 per minute. Yes. Now BP was 80 by 60, which shows hypotension. So there is positive finding of hypotension and tachycardia. Further, sensorium was alert. GCS score was 15 by 15, E4, V5, M6. That means I, he was opening spontaneously, verbal response was oriented, and on motor responses, he was obeying commands. He was admitted to the other hospital, and there were many attempts of putting Foley's catheters that were failed. TLC count was raised, that was 16K. And when he came to ER, first of all, suprapubic catheterization SPC was done after attempt of Foley's catheterization. Now HOPI patient was apparently why this Foley catheter came into the picture, because the chief complaint was urinary retention, due to which there was further symptoms we were thinking upon. HOPI patient was apparently well all night when he developed shortness of breath, which was acute on onset, gradually progressive, associated with abdominal fullness, urinary retention, and constipation. He also complains of fever with chills, which was moderate to high in severity. It was insidious on onset and yeah, progressive in nature also. Negative history of chest pain, cough, abdominal pain, and loose stools. Past history of the patient, there was no history of hypertension, type 2 diabetes mellitus, epilepsy, coronary artery disease, or any other comorbidities, but there was positive history of hypothyroidism. There is past history of electric shock 10 years back, following which patient have complete sensory motor loss below T4, and surgery was performed. There was clamp and nailing. He was bedridden since 10 years. Personal history: sleep is adequate, he's vegetarian by diet, there were no addictions, bowel and bladder habits are disturbed, that is constipation and urinary retentions are present respectively. General examination: patient was conscious, cooperative, and oriented to time, place, and person, and patient is paraplegic. Paraplegic means paralysis to the legs and lower body. Vitals of the patient: he was there was hypotension and tachycardia, respiratory rate was normal, SpO2 was normal, temperature was normal. Further, parallel and edema was present, icterus, clubbing, cyanosis, and lymphadenopathy was absent. Now edema in the foot take us into the picture of heart disease or kidney disease, and mild pallor was there, which suggests anemia. I want to tell a little bit about edema over here, because it is the finding in our patient. What is edema? Edema is abnormal and excessive accumulation of free fluid in the interstitial space or serous cavities. Pathological cause of finding edema in the patient is there is increase in hydrostatic pressure and decrease in oncotic pressure, because fluid is there now. So increase in hydrostatic pressure and decrease in oncotic pressure. Now if there is pitting edema as it was in our patient, what are the causes which we can think of? Most common causes are cardiac causes or renal causes. In cardiac causes, we can think of chronic heart disease, sorry, heart failure, and in renal cause, we can think of chronic kidney disease, liver disease such as cirrhosis, early stage of filariasis, and calcium channel blocker drugs are one of the cause for pitting edema if patient is using it. Now, investigation picture of the patient shows he's anemic. KFT picture shows increase in urea, which shows AKI. LFT was normal. Blood culture shows no growth. Urine routine microscopy shows 10 to 12 pus cells. Pus culture shows this mixed growth of growth of mixed microorganisms. ECG shows left axis deviation. USG whole abdomen shows bilateral pedal edema and bilateral mild hydrouretronephrosis. Urine culture shows E. coli growth, which is more than 1 lakh. ABG shows metabolic alkalosis. Lactate was 2.1, which shows hypoperfusion. Dengue test, IgM, IgG, NS1 antigen were all negative. Procalcitonin was 100 nanogram per ml, which clearly takes into the picture of sepsis. Malaria was positive. Malaria test was positive for P. falciparum. ESR was 60. Normally ESR lies still less than 15. Here it is 60, and it can be due to the infection. And what are the causes of raised ESR, which will you think when you will see the investigation? There's one very nice mnemonic, that is napkin, NAPKIN. N stands for, this is the mnemonic for raised ESR. N stands for neoplasia, A stands for anemia or any autoimmune disease, P stands for pregnancy, K stands for kidney disease, I stands for infection or inflammation, and N stands for neoplasia. Now, treatment which was given to this patient was injection Pantop, which is proton pump inhibitor given for GERD treatment. Injection Tizact was given, which was antibiotic. Injection Linezolid was given, which was also antibiotic. Injection Fragment was given, which was low molecular weight heparin. Injection Metrozil was given, which was also antibiotic. Metrozil ointment was given, which was for the treatment of bed sores. Yeah, patient was having grade 3 bed sores. Okay, I forgot to mention in previous history, but right now I am telling it. Syrup Crislintis was given for cough. Syrup Potlor and coconut water was given for hypokalemia, or keeping normal levels of potassium, because I remember there were normal potassium level, but it may be on borderline, and to maintain it on the good pace, we are giving pot phos and coconut water, because my dear friends, coconut water is rich in potassium. I saw in ICU that whenever there is whenever drugs are unavailable, such as pot phos, pot chlor, or any KCL like drug injection, sorry, so at that time coconut water is given to the patient. And lastly, there was given Ensure protein powder for good nutrition of the patient. And at last, the diagnosis of all this is urosepsis, because there is sepsis, and it was because of urinary retention. If you will recall the history, the story started from Foley's catheter to suprapubic catheterization. TLC was 16K. Further, procalcitonin level was 100 nanogram per dl, which was sepsis. So that's all. It was an interesting case. I hope you, after listening the history, came to learn about pitting edema and ESR, raised ESR courses. So that were good points in this video. I hope you have enjoyed listening to the case, because I really enjoyed recording it, even studying it. Bye friends.